Hello, everybody, and welcome to today's briefing on understanding what's next for Medicaid. I'm Sarah Dash, and I'm president of the Alliance for Health Policy. It's a pleasure to be here with you today. And for those of you who are not familiar with the Alliance, we are a nonpartisan organization dedicated to advancing learning and dialogue on critical health policy issues. I want to say hello as well to those of our audience who are watching us live on C-SPAN this afternoon, and to those who are joining us on Twitter using the hashtag What's Next for Medicaid. Co-moderating today's panel with me is Melinda Abrams, who is Vice President of Delivery System Reforms at the Commonwealth Fund, and we thank the fund for their partnership in organizing today's briefing. Since Medicaid was created alongside the Medicare program in 1965, it has grown into one of the most far-reaching health programs in our country, both in terms of the number of people it serves, as well as their health and life circumstances, and the cost of the program. It's run by the 50 states and territories within federal guidelines and financed by both the states and the federal government. So while Medicaid policy has national implications, it of course also has major implications for states and their citizens as well. And as we know, major changes to the Medicaid program have been at the forefront of recent health policy discussions and are included within legislative proposals in both the House and the Senate. And so today we're going to talk about what those proposals are, how they would work, and what they would mean in practice based on our best evidence and projections. And, I just want to make a special note here because while it's really easy for Medicaid policy to get very wonky very fast, and as the old kind of saying goes, if you've seen one Medicaid program, you've seen one Medicaid program, this is obviously has been an issue in our national conversation that does hit home for many people. So I think it just speaks to the need for continued respectful dialogue on the different perspectives that are brought to the Medicaid program, and that's what the Alliance for Health Policy is all about, and that's what this briefing is all about. And we're just really pleased to have a terrific panel here today to help us with this discussion. So let me go ahead and introduce our panel, and then I'll turn it over to Melinda. Cindy Mann is joining us today. She's a partner at Manatt, Phelps & Phillips. She has been a deputy administrator at the Centers for Medicare and Medicaid Services. She directed the Center for Medicaid and CHIP Services at CMS as well. Next, to my left is Josh Archambault. He is a senior fellow at the Foundation for Government Accountability. And prior to joining that foundation, he served as director of the Center for Healthcare Solutions and as a program manager for the Middle Cities Initiative at the Pioneer Institute. He also served as legislative director for Scott Brown in the Massachusetts State Senate and as a senior legislative aide for then Governor Mitt Romney. I already introduced Melinda. So next to Melinda's right is Chuck Duarte, who is the CEO at the Community Health Alliance in Reno, Nevada. And before joining CHA, he worked at the University of Nevada School of Medicine and served as the Nevada Medicaid Administrator. Finally, Dr. Richard Frank is the Margaret T. Morris Professor of Health Economics in the Department of Healthcare Policy at Harvard Medical School, and previously served as Deputy Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services, as well as a Special Advisor in the Office of the Secretary. So welcome to our panel. And Melinda has a few quick opening remarks, and then we'll turn it over to Cindy. Thanks.
Can you hear me? Hello? Great. Thank you. Good afternoon, everyone, and welcome, and many thanks to the Alliance for Health Policy and to the panelists for joining us. I've been asked to just briefly frame the conversation. As Sarah mentioned, Medicaid has taken center stage as a number of proposals to repeal and replace the Affordable Care Act have been introduced. And these proposals don't just change the recent expansion of the Medicaid program, but actually also address the underlying traditional Medicaid program. So it's timely to say, what's next for Medicaid. Before we discuss the implications and hear a range of data and perspectives, it's good to be reminded of some of the basics. So, next slide. Thank you. So the ones that are being projected, by the way, are not actually as good as the ones in your folder. So if you want to pull out your folder, then you can see some of the numbers. Just to be reminded, it's a federal and state program. There are federal standards, but states have an extensive amount of discretion on the design and administration of the program. It currently covers more than 74 million people, and that can be there are roughly 4 groups: infants and children, people of all ages with disabilities, low-income seniors, the elderly, and then other adults. Children represent the largest group, but the elderly and the disabled account for the largest proportion of expenditures. In terms of what it covers, Medicaid covers a broad range of services to meet its very diverse population. There are a number of optional services that states can cover, such as PT and eyeglasses and dental, but it's important to stress that Medicaid covers nearly half of all births, 40% of all children. There's a comprehensive benefit for children known as EPSDT, which is particularly important for children with disabilities. Medicaid covers long-term care, including both nursing home care and community-based long-term services and supports. And as of currently, more than half of the long-term care covered by Medicaid is in home and community-based, is being spent in the home and in the community, which is enabling seniors and people with disabilities to continue to live independently. The fund has, for a number of years, the Commonwealth Fund has supported research to examine the implications and the effect of Medicaid on people. And so that's what's in this next slide, is just some data from some of my colleagues off of our national survey, our biennial survey. And essentially what it shows is that people with Medicaid are less likely than those with private insurance or the uninsured to skip necessary services or medications due to cost. Other analyses look at how Medicaid beneficiaries, their satisfaction with their care, and that they rate the care actually fairly highly. But it's not just Commonwealth Fund data. There was recently, I want to draw your attention, there was recently a paper in the New England Journal of Medicine by Ben Summers and Kate Baker and Atul Gawande that did a look back and an overview of the implications and the effect of the Medicaid program, and basically showed that those with Medicaid had better access to care, more likely to have early detection of disease, more likely to be adhering to their medication regimen, had better management of their chronic condition, and really importantly, and maybe not overly appreciated, is peace of mind, knowing that they had some coverage when they got sick. So moving on, another area that we tend to look at is not just the implications for the people and the state economies, but also the providers. And this is a study that the Commonwealth Fund did with the Kaiser Family Foundation, and shows that among these primary care providers, while they were seeing more patients with insurance, most doctors reported no decline in their ability to provide quality care since the Medicaid expansion. So at the Commonwealth Fund, our role is to support rigorous analyses to understand the implications of the various health policy proposals. And really, we strive to look at the implications at multiple levels, whether it's on state economies, on providers, on people, or subsets of people. So this next slide looks at a recent analysis done by Al Dobson and his colleagues, looking at the Medicaid provisions in the House bill, the American Health Care Act, on hospital finances. And what we see is that for all hospitals, particularly those in expansion states, can anticipate over the next 10 years an increase in uncompensated care. So that's a treatment or a service for which there is no insurer and the patients are unable to pay. So anticipate an increase of about 78% over the next 10 years. Just to put a number on that, it's about $114 billion. So a big increase, but also a lot of money. In the non-expansion states, expect about a 10% increase in uncompensated care, again, over the next 10 years. May sound smaller, but still $17.3 billion. We also have analysis. Al has done a number of analyses that pull out rural hospitals, look at it by state, look at just the safety net hospitals. So there's a lot of analyses there for you to turn to. Another analysis that we released yesterday is looking at the implications of the Better Care Reconciliation Act, the Senate bill, on state economies and particularly on jobs. And as it says here on the slide, if it were to become law, we anticipate about 1.46 million jobs would be lost, affecting gross state products as well as the business output. And so really, again, and also not just looking at this at the national level, but at the state level. And so here is my little plug for some new fact sheets that we've pulled together that are in the back there for Kentucky and Nevada and California are examples that we have available, but actually there's one for all 50 states. I only covered two pieces, which was the hospital component and the jobs component, because two of our speakers, Cindy Mann and Richard Frank, will look at the implications for federal dollars to the state. That will be Cindy, and then Richard will look at a subset of the population, people with opioid addictions. And so with that, I was just going to say, echo Sarah's comment about how we really look forward to hearing a variety of perspectives and having data and evidence guide this conversation. Thank you.
Great. Thanks, Melinda. Okay, so we're going to go right down the line. Cindy, Josh, Chuck, and Richard. Then we will have time for some Q&A and discussion. And again, for those of you just joining us, you can use the hashtag What's Next for Medicaid if you're using Twitter. And go ahead, Cindy.
Okay, thank you. It's great to be here with everybody. I'm going to open it up with a little bit of an overview, short overview of the key changes in the Senate bill with respect to the Medicaid program, and then really focus my remarks today with on the per capita cap provision and its implications for states and the program and the people that the Medicaid program serves. And just want to state my appreciation for the support of the Commonwealth Foundation for its support of our modeling work. And we have looked at state-by-state impacts of both the House bill and the Senate bill. And I'll draw on both those analyses as I go through my presentation this morning. So if we want to go to the next slide, here's an overview of there's a variety of different provisions in the Better Care Reconciliation Act that affect Medicaid, but here are some of the key changes. Like the House-passed version of the bill, nobody quite knows if you're supposed to pronounce the initials or just say them out loud, but BCRA, I'll say, converts Medicaid essentially to a capped funding program, very fundamental change, as Sarah identified, in the basic structure of the Medicaid program, and really goes beyond any changes that the ACA had with respect to the Medicaid program. So it would convert, starting in 2020, Medicaid to, instead of a program where the financing is jointly shared by the federal government government's share would be limited by a per capita cap that builds up to an aggregate cap that I'll explain. That would go into effect in 2020. The bill also offers states, instead of doing a per capita cap, a block grant option, but for a limited population. The per capita cap generally applies to virtually all spending and all people in the program. There's some some carve-outs for the caps, but it's long-term care, it's acute care, it's, I think the key point is, it's not just the expansion population. People think we're talking about repeal or replace. It must be about the expansion. The financing changes are really pretty much wall-to-wall in the Medicaid program. The other big change in the bill is that it would phase out and ultimately eliminate the enhanced federal funding that the Affordable Care Act did make available for states to expand coverage to low-income adults. And you'll see on the slide that it phases out beginning in 2021, and as a 3-year drop down of the match rate, in 2020, under the ACA, it would be at 90%. It goes to 85, 80, 75%. And then in 2020, it goes down to a state's regular match rate. So big change in terms of the federal financing. There's also some provisions in the bill that would provide some extra funding for the states that didn't take up the option to do an expansion. Some funds, $2 billion of funds to those states to be shared among the 19 states. And also it changes the DISH cuts so that the expansion states continue to experience the DISH, or will experience the DISH cuts that are scheduled to go into effect.
And Cindy, sorry, DISH means?
I'm sorry, thank you. DISH is disproportionate share hospital payments. It's a special feature of the Medicaid program which provides funding on a match basis to help provide financing to hospitals that serve a disproportionate share of either Medicaid or uninsured individuals. ACA cut DISH spending on the theory that we'd have more coverage and there would be less uncompensated care. And what the Senate bill would do is restore those cuts and not put those cuts into effect. They go into in effect in September for the non-expansion states, but for the expansion states, they would go into effect, even after the enhanced match goes away. So those are some of the major things. I need to get going on this. So if you go to the next slide, it just briefly shows you what the reductions are in, if you go to the next slide, please. No. Next slide. Oh, no, back slide. All right, follow your booklet. It just shows the year-by-year reductions that CBO has identified in the BCRA. Overall, and you're probably familiar with the CBO score, CBO says that the bill would produce a loss of $772 billion over 10 years for the Medicaid program. And of course, very importantly, by 2026, CBO projects that 15 million people covered by Medicaid would lose that coverage, would no longer have that coverage. If you go to the next slide, I want to talk a little bit about how the cap works. I'm not going to spend a lot of time explaining this. It's a wonderful diagram, and hopefully it'll teach you, but we can have some time during Q&A. But the bottom line is it's a per capita cap, meaning the amount of dollars each state get is based on their historic spending, and then that historic spending is trended forward by a trend rate. And both of those factors are really critical in terms of understanding the impact to a state's Medicaid program. What was that spending in the early years? The state is kind of locked into that spending over time in perpetuity, except for the adjustment. And what you see in this diagram is that there's different trend rates that the bill picks, medical CPI and medical CPI plus 1, to bring the caps forward year by year until the year 2025. 2025, all groups go down to the CPI, which is a much lower trend rate. That all builds up to an aggregate cap. So you have your caps for the individual groups of people. You then multiply the cap times the number of people you covered in each of those groups, and that builds up to an aggregate cap, and that's what the state is going to be guided by in terms of its spending. So if state spending goes over the cap, and it starts to draw down federal dollars beyond the cap, it will have to pay back. There'll be a clawback to those federal dollars in the following year, and all of the dollars actually spent over the cap will be 100% financed by the state. So very different notion from current law, where all financing, all costs that are legitimate Medicaid costs are shared by the states and the federal government. If you go to the next slide, if you could go to the next slide, please. This just looks at how those trend rates compare. I won't go through detail on this, but let me just say the trend rates are designed intentionally to save the federal government dollars. So they are pegged at a rate that is intentionally below what it is the states are expected to spend over the next 10 years. And that's one of the main ways in which the bill achieves its some of the savings in the $772 billion score. If you go to the next slide, please. This one you might want to look at your booklet. I got a little lost in translation. Sorry, dropped my glasses. And this shows the year by year. This is our modeling at Manatt, where we showed the year by year, and we have this data by state, impact of the caps this is just the caps, not the effect of the expansion. So just part of the $772 billion. And what you see here is the federal loss of dollars, but I also want to point out, which is often forgotten, that there'll be a state loss of dollars. If a state says, I'm just going to spend to the cap, I'm only going to spend that which qualifies for a federal match, which is what most states do now under federal law. They could spend all their money on health care if they wanted to, but they generally say, I'll spend what I can spend that qualifies for a match. If they only spend what qualifies for a match under a capped environment, their state spending will also decrease. And so the total impact to the Medicaid program is bigger than the impact of the federal cuts. It's also the reduction in state dollars. Now, a state doesn't have to reduce its dollars. It can simply spend state dollars without getting a match. But on the assumption here that a state will keep below the cap to avoid that clawback and to avoid spending 100% federal dollars, you see the total cuts. And the other thing I would point out in this graph is because the CPI trend rate pops in the Senate bill in 2025, you see a very significant jump in the cuts between 2025 and 2026. Because of the change in that trend rate. And so that gives you a sense, and CBO has looked at this also, a sense of how the cuts will grow over time. They do become deeper every year, but they'll become even deeper after that 2026 period. So let me just try and make one more point here. If you would go to the next slide, please. One of the things that we have modeled is the lack of certainty of what life will be like, right? The one thing that we know is that healthcare costs are difficult to predict. But the other thing is that these trend rates are difficult to predict. So when we've done these analyses, we have taken CBO's projections of the trend rate. CBO says, I think medical CPI will be 3.7. I think CPI will be 2.4 over the next period of time. It's as good a projection as anyone might make, so I have no quibbles with their projection. But what we're showing here is that over the last period of time, and it's not unique to this period that we've looked at, is these trend rates go up and down. They're volatile. So it matters a lot which trend rate Congress picks, but whichever trend rate Congress picks, we need to understand that it is not set in stone. It is a trend rate that will fluctuate. So one of the things that we did is we looked at, well, what if the trend rate isn't exactly what CBO projects? What if the trend rate, instead of being 3.7 for medical CPI, it's just a little lower? It's 3.2, half a percentage point lower. And what you see on this is that the total cuts, just again due to the cap, would change between 2020 and 2026 from about $267 billion, it would jump to almost $400 billion, just because that trend rate changed and didn't turn out to be exactly what CBO thought it would be. So just to close, I think that's one of the most important points we want to make about the fundamental change in financing of a cap, is it, yes, produces significant reductions in federal dollars to states for their Medicaid program, but it also introduces a great deal of uncertainty, and all of that risk of uncertainty of the trend rates or of actual health care costs are going to be borne by the states, by the Medicaid program and by the beneficiaries. Stop there.
All right, thank you. All right, Josh Archambault.
Great. Thank you so much for the Alliance for Health Policy and the Commonwealth Fund for inviting me. Just for those that aren't familiar, FGA is a think tank that works in roughly 35 states. We also work here at the federal level on health and welfare reform. So I want to start with a poll. Raise your hand if you think, based on the media coverage, at the end of the 10-year CBO budget window, we'll be spending less money on Medicaid. Raise your hand. Raise your hand if you think we're spending more money at the end of the 10-year budget window. A couple people? Okay. I'm just saying absolute dollar amount if you compare what we're spending today versus the future. So I think what we have found around the country is the media coverage has used this language around cuts, massive, severe cuts. But what's interesting is that for years we've had agreement on the right and left in the health policy world that we want to slow the rate of growth in healthcare in general. Yet, we have a proposal on the table for the Medicaid program to slow the rate of growth, and the sky is falling. Now, there's lots to unpack here, so I want to start a little bit and talk about the status quo. I want to make sure that anybody who is talking about the changes in the Republican bills has to also talk about the status quo. From the standpoint of the Medicaid expansion pits the able-bodied adult, who are part of the expansion population, against the traditional Medicaid population. Let me explain that. So the federal government put extra money towards the Medicaid expansion population to try to get states to expand. The challenge with that is that if I'm a state budget writer and I have to balance my budget every year, which, by the way, they do, unlike here in Washington, they have to, if they have to find $1 of savings, determine where they're going to try to take that $1 of savings. They've got a few different options. I'll tell you, first and foremost, that when it comes to Medicaid, it comes out of the traditional Medicaid population, the elderly, kids, the disabled, because they lose less federal dollars if they do so. If it doesn't come out there, then it comes out of education spending, public safety, infrastructure. We can't spend the same dollar twice. Secondly, as far as the status quo is concerned, we can't assume that federally we can actually sustain the spending that we have. If you look at GAO, CBO, look at any of these reports historically, when they look at social SSI, Medicare, and Medicaid, they're going to eat the federal budget alive over the next 50 years. And for us to just assume that we can't do anything for reform, I think is naive, and is also going to hurt people more in the long run. The deeper concern that we have is I don't think the Medicaid program in general has lived up to the promises that we've made to the truly needy before making new promises to the expansion population. I also would say that the current open-ended structure actually leads to some pretty terrible state behavior. The New York budget director for a long time had this somewhat glib statement saying, if it moves and Medicaid can pay for it, then Medicaid, put it in Medicaid so that we can pay for it, things like school services. And if not, depreciate it if we can't pay it off. At the heart of that, what that is to say, we're going to try to just pull down as many federal dollars as possible. The focus is not about program integrity, coordination of care, health outcomes, and as I'm sure many of you are aware, there have been some questionable, whether it's the Oregon study or others, looking at questionable outcomes on Medicaid. So if we have a program that estimated to deliver about 20 to 40 cents of value for anybody, why would we just defend the status quo? Why wouldn't we be open to trying something new? I do think that from the state perspective, we work with a lot of state legislators and governors, and when it comes to Medicaid, one of the things we hear in blue, purple, and red states alike is additional flexibility. They want and desperately need additional flexibility on Medicaid. So what does that mean? Well, it can mean a few different things. The first thing is that the waiver process here in Washington, it does allow for, in theory, a lot of flexibility. But when you're a state legislator needing to balance your budget, when you're a governor needing to balance your budget that year, but the average waiver request takes over a year to get approved, it's not as helpful in the short run. So giving them the flexibility to grandfather new eligibility changes going forward, to do more frequent eligibility checks, to reinstate asset tests, are sorts of things that governors are starting to look at, especially in light of some of the proposals that are on the table here in Congress going forward, of what they want to do to move forward. I'll just say that on the per capita cap proposal, this used to be bipartisan. President Clinton had a proposal in 1995 along these lines. There have been Democratic governors in the past. I live in Boston. Former Governor Deval Patrick talked a lot about the need to bend the cost curve or reduce the rate of increase in Medicaid. So I want to make sure that we're having an informed, intelligent discussion about what the actual changes are going forward. What's interesting to note is two things. One, for those that were supportive of the ACA, there were over $700 billion in reductions in payment in Medicare. I don't recall seeing the sky is falling rhetoric around that time. In fact, I went on the Commonwealth Fund website to look, and what I found was Karen Davis, who I believe was at the Commonwealth Foundation, testifying about this was positive. In fact, she said more is needed to have a sustainable program, and she laid out a number of different proposals to do so. But I think it's just interesting that we have people that want to have it both ways. If we recall, in welfare reform, in the 1990s, the sky was falling during that reform as well. And what was missing from that discussion, similarly to I think what is missing today, is that there's two components here. There's a tax credit. In welfare reform, there's the earned income tax credit. In healthcare, there's a tax credit, and there's a robust debate to be had about how generous it is, who's it offered to. But in the Medicaid space, when the state decides to move away from Medicaid expansion, there's a tax credit available for those that don't have employer-based insurance. In non-expansion states, for people who aren't currently qualified for Medicaid, there's a tax credit available, newly available under the Republican health care bill. That should be part of the conversation that we're having about holistically looking at the decisions that people are going to be made. Now, I'm not really interested in kind of closing to poke CBO too much. However, I will make a couple comments here about the coverage losses that we keep hearing about. What we need to understand about the process, and it's very arcane, and I get why the public doesn't follow it, but they modeled off of 2016 numbers that had a number of assumptions about how many people were going to sign up in the individual market and in Medicaid. They didn't model off of updated numbers in 2017. So this 14 or 15 million lives number that we often hear about people losing Medicaid coverage, it's not losing technically, it's changes. And there's a couple things baked in there that are just phantom. For instance, they say that 5 million of those are people who lose coverage in states that they thought would expand Medicaid. Well, if you're not on Medicaid, I'm not sure how you can lose it. They also make some assumptions around the individual mandate that 5 to 7 million people will just decide from this year to next year that are on Medicaid now, effectively a free insurance program, that they're just going to stop signing up. I think there are some reasonable questions to be raised about whether that's a safe assumption going forward. So thank you for the opportunity to share that. Look forward to the Q&A, as I suspect I may be sharing slightly different perspective at times than others on the panel.
Great. Thank you, Josh. And I know most of the people in this room are very familiar with the Medicaid program and the policies, but just since we've talked about both the expansion population in Medicaid and the per capita cap, I just want to kind of raise a clarifying point as well for those who might be watching on C-SPAN that who was in the Medicaid expansion population. Can Cindy or Josh, one of you, give that quick primer and overview of that?
Sure, happy to. So a lot of people, I think, thought before the ACA that poor people got Medicaid, old people get Medicare. Their Medicaid grew up over the years. Congress changed it over the years, but there was always a missing group of people. So parents could get coverage, pregnant women could get coverage, children could get coverage, people with disabilities and elderly. And if you didn't fit into those boxes, but you were still poor, you actually didn't qualify for Medicaid, and you'd have to come and get a waiver, and it would be complicated. And so what the Affordable Care Act did is said people should be eligible for Medicaid based on income, not based on family circumstances. So by filling in that gap, what it meant is the expansion group are parents above the income level that a state was covering before the ACA, well below poverty on the average, and so-called childless adults. I always say so-called because in Medicaid language, a childless adult is somebody who's not living with a dependent child who's under 18 or 19. So I'm a parent, but I'm not a childless. But in Medicaid language, I would be a childless adult because my kids are 19 and 20. So it's adults that aren't pregnant, aren't disabled, aren't elderly, and up to 138% of the poverty line.
And just one more quick clarifying question. So that 15 million number that was in the CBO score, is that mostly related to that expansion population, or is it related to other populations that are covered under Medicaid?
Yeah, CBO doesn't identify it that precisely. We think it's mostly related to the expansion population, but there will be some implications because of the reductions in the federal funding that we went through the cap. But exactly how any given state might address those reductions, I think, are somewhat speculative. So I think it's mostly the expansion, but it's the combination. They don't pull it out.
A point of note for context, roughly about 75% of the growth in spending in Medicaid is due to enrollment. It's not due to underlying healthcare costs or other things going on. So when we're talking about savings going forward, it's frequently related to enrollment of some sort because that's where we've seen the explosion, both in the expansion and in the non-expansion population.
Great, thanks. And we will get to the intersection of the Medicaid program, the expansion changes, and the tax credits that Josh, that you mentioned. But before we get to that, which I do want to get to in the Q&A, we're going to give our other panelists a chance to share their remarks.
Good afternoon, everybody, and I want to thank the Alliance and the Commonwealth Fund for having me here. My name is Chuck Duarte. I'm the CEO of Community Health Alliance, and by way of background, I wanted to tell you a little bit about myself. Besides running a community health center in northern Nevada, I spent 15 years running Medicaid programs on the front line as an administrator, 12 years in Nevada and 3 years in Hawaii. And before that, I ran community health centers in Hawaii. I started a managed care organization, a nonprofit FQHC-owned managed care company in Hawaii. Worked in hospitals and laboratories and a number of other things. And I'm going to start with a poll, too. How many of you folks here have ever touched a patient as a professional practitioner? How many? Well, I'm actually glad to see a lot of hands going up. That's wonderful, because one of the things I warned Sarah about is that I'm going to wear my heart on my sleeve. And one of the things that, I'm going to borrow a line actually from a friend of mine who's in the audience today, and she said, you can't only break heads with data, you got to break hearts. And you talk about this because there's a patient at the end of your decisions. And that's very, very important to keep in mind. So part of my job is to tell you about that, but also to tell you about what happened in Nevada, Nevada being a very pivotal state in this discussion, and also as a Medicaid administrator, a former administrator, what I see as the tough decisions coming up for Medicaid administrators and governors throughout the nation. So again, my name's Chuck Duarte, if you wouldn't mind changing the slide. I run Community Health Alliance. It's a nonprofit organization in northern Nevada. It's a community health center. We have 6 health centers in the county of Washoe. We have mobile services, medical, dental, and nutritional services, and we provide integrated medical and behavioral health care, as well as dental, pharmacy, and nutrition programs to our patients. Next slide. We serve about 30,000 unduplicated patients a year, 44% of whom are children. We have 100,000 annual patient visits. 60% of our patients indicate that they're of Hispanic origin. 95% of our patients are below 200% of poverty. Most of them have Medicare, Medicaid, or are uninsured. Next slide. What I'd also like to do is tell you a little bit about Nevada and give you a snapshot. And so the first thing you have to learn how to do is to say Nevada. So after me, Nevada. It is not Nevada. If you go there and say Nevada or Nevada, waiters will refuse to serve you and dealers will deal from the bottom of the deck. So do not do that. So Nevada is in the crosshairs. And what people don't understand about the state is that you think about Las Vegas, and Nevada is really a frontier state. It has two population islands, Las Vegas and Reno. Reno's up in the north and Las Vegas is in the south, and they're 500 miles apart. And you can go across the state the other way, and it's 500 miles of nothing. And so 14 of the 17 counties in Nevada, pardon me, have about 10% of the population. And, excuse me. And so they have benefited greatly from the Medicaid expansion. And if you look at the population in a snapshot, and this is from Kaiser, 35% of Nevada are low income. About 2/3 indicate that they're obese or overweight. 1/3 indicate that they have a mental health condition, and 10% have diabetes. In terms of opioid deaths, we're ahead of the national average, 13.8 per 100,000, and we're 7th in terms of the rate of HIV diagnosis. Next slide. So this one slide kind of tells the story. If we wouldn't mind going back one, Jared? Now, looks like it's not going to work. Okay, so if you folks can go to your handout, hopefully you have this in your handout, but there is a slide that shows you the change in the uninsured rate in Nevada between 2013, and it says 17, but it's actually 15. So 1 year after Governor Brian Sandoval, our governor, implemented the Medicaid expansion in 2014, and the Silver State Health Insurance Exchange, we saw a drop in the uninsured rate within 1 year from 19% to 11%. Nevada boasted the second highest uninsured rate in the nation behind Texas at that point, and it changed dramatically with the implementation of the Affordable Care Act. I saw a recent statistic that for non-elderly Hispanic adults, the uninsured rate has dropped from 34% to 19%, and that's the slide I was referring to, I'm sorry. Next slide, please. Oh, it's backwards. Yeah, sorry. Okay, now we're all right. So this slide shows you the impact of Medicaid on Medicaid, or the ACA impact on Medicaid caseloads, and this is from the state budget. And so you can see where the Medicaid expansion happened in 2014. And between 2014 and November of 2016, caseloads have grown from 330,000 to 630,000. The two groups that Cindy talked about, new eligible parents or parent caretakers and new eligible adults, they represent about 230,900, and that's 900 of the total population. But what's interesting here is that not only did those two caseloads increase, the new eligibles, but we saw a pretty substantial increase in the traditional caseloads of aged, blind, disabled, and moms and kids. And why did that happen? Primarily because of the woodwork effect, people becoming aware of Medicaid and saying, gosh, I'm eligible for Medicaid and so are my kids, or my disabled parent or sibling is now eligible, or spouse. And so it was the message that got out there that had these people apply, and they are eligible as a result of the traditional program. And so any cuts that occur in the state are going to have to, and I'll say cuts, I'll talk about that in a bit, are going to have to come not only from the new eligibles, but are going to have to come from the traditional populations. Next slide. And then the next slide. Okay, I'm going to keep rolling. Right there, stop. Okay, so this is our patient population. And so you can see before and after the expansion for children in our practice. In 2013, we had 41% uninsured children. Today it's 17%. For Medicaid, our children's enrollment went from 58% to 73%. For adults, it declined from 78% to 22%, and Medicaid enrollment went up 300% from 10% to 43%. Next slide. And this is what I mean about breaking hearts. And so Josh mentioned the able-bodied, people that, they just got on Medicaid because they could. Well, this is one of those so-called able-bodied individuals, and this is a story published by Nevada Public Radio about a lady who's a patient of ours. Her name is Angela Siegfried. She is in our Center for Complex Care, which is a specialized community health center for people with complex medical conditions as well as behavioral health problems. She has type 2 diabetes and COPD. And here's a quote: "I would just get really sick and end up in hospitals and emergency rooms. They keep me, get a little bit well, and send me on my way." Now, she is a beneficiary of the Medicaid expansion. She worked as a bank loan officer, but became too ill to work and lost her insurance. She now has Medicaid coverage and is spending time with her grandsons. I quote, "I go to soccer games, I go to church, I'm not bedridden. I don't ever want to be in this life without insurance. What's going to happen?" Now, she is not a unique individual in this situation. Of people who are in our program, in our health centers, who are expansion eligible, a lot of them are disabled, but they don't qualify for SSI. 35% of them have a mental health disorder and a concomitant substance use disorder. Many of them have chronic conditions. And so you can't tell me that these are all healthy, able-bodied people that are going to go right to work when there's a job opportunity, because they struggle already and they do work. And so, again, I'm wearing my heart on my sleeve, but that's extremely important to understand about this population. And these are the people that are going to be affected. Last slide. And the last thing I want to do is kind of give you an idea of what Medicaid administrators and governors are going to have to do, and particularly in the state of Nevada. So the Urban Institute just put out a statistic, and there's been some other numbers thrown around just in the last 2 days about the loss of federal revenue to Nevada. And by 2022, the Urban Institute estimates that Nevada will lose $1.4 billion in federal Medicaid funding. That would be a 43% reduction. Now, granted, the CPI is going to be there, and there's going to be an increase in spending, but 43% reduction in federal funding is going to result in people losing coverage. And so the other complicating factors in Nevada is that we have a relatively high match rate, and so the loss of those federal funds is going to be equally significant. And we have a high expansion population. We also have a high chronic disease burden in a lot of these folks in the expansion population, a lot of mental health disorders, addiction, HIV infection. We have rural and frontier counties, which are going to be adversely affected by this. We have a rapidly aging population in Nevada, which are going to be ultimately dependent on home-based services or nursing home care, and we have a low tax base. And so what are governors going to have to do? Well, I've got 4 dials there that Medicaid directors usually adjust, and I'll talk a little bit very quickly about some of these, because these are the decisions that governors and Medicaid directors are going to have to make. The 4 buttons are eligibility, services, utilization, payments, and there's a little control button on the bottom called managed care, if you can't see it. And so eligibility, you can do things like put work requirements on, asset limit increases, income limit increases. You can do things like doing more frequent eligibility determinations. All of those things have the net result of knocking people off the program. And that's fine. But the real big gun on eligibility is you got to take whole populations out of the program all at once. That's the only way to get the costs out of the system. And so you've got to get rid of the expansion population, and you've got to get rid of some of the people involved in the traditional program. And that's where the cuts are going to come, or reductions, I should say, reductions in spending growth. For services, you can look at eliminating optional services, prescription medications, personal care attendant services, but those have collateral cost impacts on the rest of the program, and it's not necessarily wise to cut those services. You can look at utilization management. Those really just have marginal impacts, and you can't be willy-nilly about it because states are required to maintain a reasonable medical necessity criteria when they look at utilization management, so you can't just do that. You can look at cutting payments, but of course CMS is still looking at whether or not cutting payments has an impact on access. And so you can't just willy-nilly cut payments. And then there's a little control button on the bottom. It doesn't do a lot, but people like to press it a lot. It's called managed care, okay? And I can say that from my experience in 15 years in running Medicaid. It's great. I call it the Punch It's pilot program. Governors can say, I wash my hands of thee, I give it to the managed care programs, and be done with it. That's why they do it. It doesn't save money, people. And then finally, I would like to say that, again, if I'm talking to a patient who's going to lose coverage, I'm going to tell them, I'm going to borrow the line, don't worry, it's not because of cuts. It's because of reductions in spending growth that you lost your coverage. So it's not a problem anymore. So again, I'm sorry to wear my heart on my sleeve and not be totally data-driven, but I had to do it. Bye.
Well, it sounds like a couple of lessons here. Language matters, but consequences, whatever they may be, are going to happen one way or another. So we'll keep talking about that. But first, we have one last presenter, Richard Frank, and then we'll get into a discussion and Q&A. Thanks.
Thanks. I'm happy to be here, and I really wish I had Chuck's social skills. But I'll keep going. I'm going to, can I have the first slide? Or the next slide. Next? Yeah, that one. So I want you to walk away with 4 takeaways. First of all, I'm going to really focus on Medicaid and its role as a tool in addressing many of the types of public health emergencies that we've been facing over the last few years. Opioids, Zika, flu, you could throw in diabetes and asthma if you'd like. And what I'm going to really do is focus on opioids as a tracer condition for this broad set of sort of public health threats and how Medicaid works to give us tools to deal with it. Second is by expanding access to preventative interventions and treatments, Medicaid is an important part of the arsenal that most governors are using to fight the opioid epidemic, both in terms of addiction itself, but also in terms of the mortality consequences of the addiction. Third, the proposals to repeal the Medicaid expansion and then to shift to a per capita cap will be destructive to state efforts to rein in the opioid epidemic. And I'm going to show you a little bit of an illustration of the kinds of pressures that are put on states under these types of arrangements. And then last, the monies that are being proposed, and there's a lot of recognition in various parts of Congress that certain kinds of public health emergencies are being threatened, and the opioids in particular, and that none of the proposals that I've seen will come near providing the kinds of money you need to kind of deal with that problem. And you can imagine that going down the road. For example, we've recently seen there's an uptick in methamphetamines that nobody's even started to talk about yet. Okay, next slide, please. So let me start off with some fun facts about opioid use disorders. The first is that in 2015, we had over 53,000 people die from overdoses in this country, and about 61% of those, or a little over 33,000, were due to opioid use disorders. The overdose death rates grew at 15% between 2014 and 2015 nationally, but in fact, this is not a new problem. The opioid epidemic has been going on since 1979. It has grown pretty steadily at 9% a year since 1979 with respect to mortality. And because the opioid epidemic and opioid use disorders are concentrated in low-income populations, you see the Medicaid expansion population being responsible for treating these folks. And for example, in a state like Maryland that expanded Medicaid, roughly 2/3 of the people that died due to an opioid overdose were enrolled in Medicaid. Now, it turns out that about half the people with an opioid use disorder also abuse or use other types of drugs, methamphetamines, alcohol, cocaine, among others. And a large number of them suffer from chronic diseases, some of them directly related to their opioid use, but some of them not. So HIV, hepatitis C are two that are, but there are other illnesses such as diabetes and asthma that also tend to accompany opioid use disorders. And so what that means is that the average amount of spending for a person enrolled in Medicaid who has one of these disorders is somewhere around $11,000 to $12,000 nationally. To put that into perspective, treating somebody with medication-assisted treatment for a year costs $5,500. So that means half of their costs are not directly related to their treating that disorder, but are related to all sorts of other problems that they have. Next slide, please. So this is to illustrate the impact that the expansion population has had on prevention efforts. And there's a drug called naloxone, which reverses opioid overdoses. And what you see in front of you is a comparison of the growth in the use of naloxone in the Medicaid program in expansion states relative to non-expansion states. The steeply increasing one is the expansion states. The modestly increasing one is the non-expansion states. And what we've seen is exactly coincident with these increases is aggregate data showing that between 2013 and, say, 2014, there was a doubling of the use of naloxone to reverse overdoses. So Medicaid is contributing to getting more of the opioid reversal, overdose reversal drug into the right hands at the right time in order to sort of save lives. So really this graph is a reflection of the number of reversals that have occurred as a result of making the drug more available. Next slide, please. Now we're going to do some arithmetic. And the arithmetic here is not meant to be a precise estimate of the future, but rather to illustrate the kinds of pressures that states are going to be under as they sort of fight this epidemic. So this is the case of West Virginia. In 2016, West Virginia spent $242 million on substance use disorder treatment in the non-expansion part of Medicaid, okay? So, and the growth rate of utilization of health services has been at about 5.7% a year for the last 10 years. And so if you start to move out the spending along that trajectory, you see that by 2026, you'd expect the main part of the Medicaid program, the non-expansion part of the Medicaid program, West Virginia, to spend about $445 million a year on substance use disorder treatment, okay? If we grow that by the CPI-M, which is the more generous of the indexes being proposed in the two health reform proposals, you see that you come up with about $368 million of spending. Now, the difference there is $77 million, and clearly not the whole difference is on the table, but recall that West Virginia has a very high matching rate, 71%, so in fact, over about 55 million of that would be a difference in the federal spending. And so I think this is not meant to do anything but illustrate the kinds of pressures that states are going to be under. Last slide, please. Now, let me turn to the expansion population. West Virginia treated about 50,000 people in the expansion population for a substance use disorder in 2016, okay? And the spending that corresponded to that, those 50,000 people, was about $112 million, okay? Now, if that goes away, and I'm not indexing to the future, those dollars will no longer be available since roughly we're still paying just about 100%. And what does that mean? That means that those people, those 50,000 people, are going to have to look elsewhere for treatment, and the state's probably going to have to take it on. Now, just to put that into perspective, let me take that $45 billion that's been proposed in the Senate to deal with substance use disorder problems, and I'm going to allocate it the way that the 21st Century Cures dollars are allocated, okay? West Virginia would get $61 million a year, okay? So right off the bat, you're taking out $112 million first day, and that's got to continue to grow, and then the $61 million is every year, and it doesn't grow. That's all I have to say.
All right. Thank you, everybody, for your very thoughtful presentations. Thank you all. It's a little cold in here. But we're going to get to the discussion portion. And so you guys have a couple of options for asking questions. As usual, your green cards, if you want to write a question down, someone will come pick it up for you. There are also 2 mics right there that you can come and ask a question, or you can send it in on Twitter at hashtag What's Next for Medicaid. So let me kind of let me try to pull us back and kind of frame this. It seems like what's coming across from a lot of the comments are there's a couple of issues that we're really talking about here. One is, what is the right way to offer coverage to low income people who have, they may be healthy, they may have significant chronic conditions, but they don't qualify based on the basis of a disability or a functional limitation. So one question is, what's the best way to offer coverage? And then the other is, what's the best way to offer long-term services and supports and finance all of that? So what I'm curious about is, from the panel's perspective, what do you see as, what is the fundamental issue here that needs to be solved, or issues that needs to be solved when it comes to looking at the Medicaid program? Josh, you mentioned, of course, the slowing the growth rate in spending, which is something that we're talking about not only here in the Medicaid program. There's a little debate brewing over IPAB, the Independent Payment Advisory Board, that would also or reduce the growth rate or have a cap on the growth rate in Medicare spending. And one thing that's outside the scope of this briefing, but is nonetheless, also was part of the Affordable Care Act, is part of the legislative proposals, is this Cadillac tax, this sort of cap on employer-sponsored coverage. So are we being a little schizophrenic in how we're approaching this question? So a lot of kind of pontificating from my end, but really the question for the panel to kick it off is kind of, what do you think is the problem that we're trying to solve here?
Well, I would just step back for 1 second and say we need to decide whether Medicaid is a health insurance program or a welfare program, and depending on your answer to that question, you will change the structure of it. The other thing is the goal for people, since it is largely an income-based program, is the goal for people to be on it for a long time? I would answer no. So anything that we can do to help people to get off, because it means by definition they're poor, we want to do. So I think that there's a lot to that you can peel back. Why can't they afford insurance? So we get into all these other questions about scope of practice and regulations, which I don't think we're going to focus on today, but I do think that that's part of this answer. But ultimately, I think what we need to ask ourselves is having somebody on a program for 20 or 25 years, that means by definition they remain poor and probably not working as much as they want or working at all. In Ohio, the Medicaid expansion population, 60% of them are not working. That should be deeply concerning to you, no matter what your view of Medicaid. We want to make sure that individuals don't get stuck that are able to work. I think that's a bipartisan goal, perhaps not anymore in this country, but I think that's what we need to start to ask ourselves. And I know other panelists are going to say you can't get everybody to work. I get that. But for those populations that we can, we certainly should be focused on that across programs. So if you're on SNAP, on food stamps, or on TANF, or you're on Medicaid, we need to understand that our goal should be to coordinate and get people off as soon as possible onto affordable private insurance, which is that whole other conversation.
Richard? Sorry, Cindy. Richard, why don't you go next?
Yeah, I'm going to speak as an economist here, and so money is the problem. People are poor, and but I want to get to this issue of cut versus growth. Looking around the audience, there's like 3 people in the audience who remember Ronald Reagan, but Ronald Reagan had a thing called the misery index, which had to do with inflation. And in fact, if you look at CBO, if you look at everything, none of the projected index rates in Medicaid are keeping up with CBO's projected increase in healthcare inflation. And to kind of say that, okay, the absolute dollars are going to grow, but we're going to pretend there's no inflation, seems like really misleading. And so I think the problem is money. The problem is money in two places. One, people are poor, and even when they work, they don't have enough money to buy health insurance. And two, budgets are tight, and in order to pay for poor people, you need budget dollars, and they need to keep up with real resources.
Chuck, you want to go next?
I'd love to go next.
Okay.
Thank you. So, again, I'm not as smart as Richard, but we're talking about money. And, calling Medicaid, excuse me, I'm losing my voice, but calling Medicaid a welfare program is kind of an interesting concept because welfare has a connotation that goes back to the 90s where people were getting cash assistance. And Medicaid doesn't provide cash assistance. It provides a service. It pays for a service. There are no dollars given to a Medicaid beneficiary as a result of them being on. It protects them from financial bankruptcy. And these are poor people to start with, okay? And so they're struggling day to day, if they're working or even not working, to make sure that they can put a roof over their head and food on their table. We have a food pantry. We get about 2,000 people a month that come in and don't have food in the refrigerator. And a lot of these are expansion population folks. And we give them food until they can get to the food bank or SNAP. And so you're talking about the economy of a household where Medicaid does not contribute to the economy of that household, but it provides protection, a safety net for that household so it doesn't collapse. I think if you look at the root word, and Richard would know, the root word of economics, it's oikos, and I think it means home. And so the whole root of economics has to do with the sanctity and the protection of the home. It got bastardized in the 1700s by the English and became something totally different. But there is no dollars associated with Medicaid. So again, I don't consider it a welfare program at all, and I've been involved with it for 15 years.
So as we pass it down to Cindy, I just wanted to add that I don't think it's just about being poor. I think it's also about being sick, that the program is also there for people who are really sick, who maybe because of their illness, they have disabilities, and it is harder for them to work and harder for them to afford the extent of care that they need. Cindy, what problem are we trying to solve?
Good question. As Josh noted, actually, in his earlier remarks, per person, per enrollee, Medicaid cost growth have been well below the cost growth of commercial insurance and of Medicare. It's not a runaway cost in terms of, oh my God, it's just getting more and more expensive. Medicaid spending has increased because, again, as Josh also said, it's covering a lot more people. It has filled in that gap that existed before the ACA, and as Chuck also talked about, it has welcomed other people into the program who were always eligible but didn't know that they were eligible and have applied. So what problem are we solving? It's covering more people. It seems to be why the growth in the Medicaid dollars are there. Is that a bad thing unto itself? Well, Josh has proposed that people shouldn't be on Medicaid. They should go to private insurance. They should get themselves out of poverty. I'm all for solving poverty. And we ought, and I don't mean to be glib about that. It is a really important issue. It's not really the Medicaid program's role to solve poverty. But also, as Melinda said, I want to stress that Medicaid is a very diverse program. We're talking a lot about these now childless adults, but a third of the spending for Medicaid is for long-term care, is for Medicare beneficiaries who don't get long-term care services through the Medicare program, not extensive long-term care services. We have people, pregnant women, we have people who are totally and permanently disabled. Those are where the big costs are in the Medicaid program. So we really need to keep keep our eye on the ball of the diversity of the population and the services. And finally, just if we want to focus on how to cover very poor people, okay, let's look at the tax credits that are offered under the Senate bill. That would be offered to people down to 0% of the poverty line. So at the poverty line for a single individual, $1,000 a month. 50% of the poverty line, $500 a month. Not to spend on health care, to spend on food, to spend on rent, to spend on utilities, to spend on transportation, to spend on every single need, including health care. You can get a subsidy under the Senate bill if you're at 50% of poverty or 0% of poverty or 100% of poverty, and you will get a subsidy to help you afford the premium. There'll be that premium actually is pretty modest. There will be many very low-income people who can't even afford a modest premium. But let's assume for a moment they can afford that modest premium. We looked at what the deductibles will be. We looked at Arizona in particular, and we also looked at national data, and we looked at actually what the premiums are in the marketplace in Arizona in different counties. And if you take the deductibles that policy will end up requiring, plus the premiums, but it's mostly the deductibles, then as a percent of income, buying that coverage through the tax subsidy will consume between 76 and 90% of your total income if you're at 100% of poverty, right? No room for food, no room for rent, no room for anything else. Medicaid fundamentally is about providing affordable coverage for people, and the tax subsidies that are being proposed as an alternative just don't cut it.
Thank you, Cindy. So, I mean, I think let's just, since we're kind of on this topic, get into this question of, right, like private sector alternatives to Medicaid coverage is part of the challenge here. Seems to me that, you know, starting from its origins in 1965 as, you know, medical assistance for people who basically were receiving cash assistance, and the program has grown and grown and grown. But, you know, is that in response to, you know, frankly, failures to address the problem in other ways, to have a functioning private insurance system that can be affordable for, you know, people of any income? You know, I don't know if anyone wants to try to take that on.
So the short answer is yes. There's lots of work to do, and that's probably what I spend about 50% of my job doing at the state level, is trying to help states crack that code. But I want to return to one thing I said at the beginning. Anybody that criticizes the reform has to defend the status quo. So let's not pretend that we can keep doing what we're doing. We can't. And so while I appreciate Chuck's passion and Cindy's passion about this, this is deeply personal to me. I've had family members on Medicaid. You have three choices. You can try to come up with a reform now to try to make it sustainable going forward. You can defend the status quo that is going to hurt the traditional Medicaid population, or you can kick the can down the road and have even deeper cuts in the future. Which one do you choose? That's what we're talking about here. So while there's lots of sniping in the media about it, and listen, I'm not here to defend everything that's in the Republican healthcare bill. Trust me, it needs a lot of work. However, when we talk about reform, if we want to keep any sort of promises, we have to change it. And let me just make one last point here. For us to defend Medicaid as a great coordination of care, I mean, Chuck knows this firsthand. When I talk to Medicaid directors and others around the country, they're so frustrated with people going to the ER on Medicaid, because we know that's not the best way to get your care. Everybody agrees on that, yet it's a persistent problem. And so for us to say that this is some great silver bullet where we're delivering the best quality care, it's simply not true. And there's a lot of ways to fix it. And when you also talk about the per capita caps, if you put that back since 2000, I don't think any state would have exceeded their per capita cap. And the growth rate in the House bill, and in your packet is an analysis that we did on the House bill, the growth rate for the elderly and the disabled is much more than what our projected growth rates are for those populations. So we just need to understand, yeah, there's lots of moving parts here, but let's at least understand that the dynamic going forward of the impact and whether we actually think the status quo is something we can sustain, and I would argue absolutely not.
want to give her an opportunity to ask her question.
Oh, thanks very much. Caitlin Connolly with the National Employment Law Project. I want to just ask a little bit more about home care and long-term services and supports. But first, I want to say that beyond your 3 suggestions, there's 4, which is revenue, addressing revenue, and not, giving tax breaks to the wealthiest. Going into long-term service and supports, which we know Medicaid is a primary funder of, and plays a huge role. And as we are looking at an aging population, demographics that we've never seen before, this legislation will, harm our current system and our future one in even greater ways by both, per capita caps will not adjust for higher costs for the old population, those who are 85 and up, and also the job losses, particularly, in addition to the 1.5 million projected, that the specifics of those in the home care workforce. We're looking at Leading Age and Community Catalyst released a report saying between 300,000 and 700,000 home care jobs could be lost because of these cuts, and that's just at the time when we need even more home care workers to meet that demand. So I wonder if you could address that, and then also the 1.5 million job losses by 2026. Were you able to account for the even greater potential losses when Medicaid by 2036 is cut by 35%?
Just taking on that last piece first, since the analysis just went to 2020. It's done by Leighton Koo at George Washington University. You can look at it up on our website, and it projects out 10 years to 2026. Sure.
So I'm going to go back to my previous life. This is Chuck, as a Medicaid administrator. So one of the things I'm most proud of in Nevada is that we flipped the expenditures between nursing facility care and home and community-based services over a decade. It took a decade. And that was by establishing programs like personal care attendant services and making sure that they were funded adequately so that we could, not only in urban centers, but in rural communities, be able to take care of people at home. And so I'm very proud of that, as well as expanding home and community-based care. And so your point is spot on. And I don't disagree with Josh that, we can't continue to see increases in the healthcare percentage of our GDP. But we have to find a way to make it more affordable. And with an aging population in Nevada, we're the second highest growth rate projected for 85 plus individuals. And they're going to be ending up in HCBS services or in long-term care and facilities. And we have to find a way to make that more affordable. And your 4th suggestion is spot on. It's revenue. I mean, how much does it cost? I worked for Blue Cross Blue Shield in the 80s, and I started a long-term care insurance product. It cost me, when I was 30 years old in premiums, it cost me $5 a month for HCBS coverage through Blue Cross Blue Shield. And I could have continued paying those premiums. Now, if we charge people $5 a month as a part of either their Medicare program taxes or other taxes, we could be able to afford, in the long run, payment for HCBS services for individuals. Maybe not everybody, but we'd have a modicum of services there that could be income adjusted and would provide for adequate long-term care services. So revenue would be a solution to that problem, looking at our growing elderly population.
So thank you. And we actually, we've been talking so much, we only have 12 minutes left in this briefing, so I want to just kind of make a note over here that this issue of, long-term services and supports financing is obviously a huge issue, and I think there's some reports coming out around town on that issue, and certainly something that we plan to look at in the future, separate from this discussion. But I want to get to one of the questions on the cards. We've been talking a lot about adults and older Americans. I believe Melinda mentioned the statistics on how many children are covered. This is a question for Cindy, since you ran the CHIP program as well. What are the intersections between CHIP and Medicaid and some of the changes that are proposed, and how would CHIP be implicated in all of this?
Right, and I appreciate the question, whoever sent it in. because it's often overlooked that Medicaid is such a significant player in the lives of children across the country. About 40% of children around the country get their coverage through healthcare, through the Medicaid program. The CHIP program, as is often said, stands on the shoulders of the Medicaid program. It's a little over 8 million children covered through the CHIP program, about 37 million children covered through the Medicaid program. Both cover some healthy children, but Medicaid covers the lion's share of the kids who have greater health care needs. And so CHIP has been enormously successful, has a lot of bipartisan support. It's really helped with continuity of coverage, helped make sure that that uninsured rate has plummeted for children over the last 10 years. It's now below 5%, thanks largely to Medicaid and CHIP. But it functions a lot because Medicaid sits beneath it. It's covering so many more of those children, and it's covering the children with the higher health care needs. So you really need both to complement each other in order to maintain the coverage and the health outcomes that we've seen for kids over the last few years.
Let me kind of follow on that. We actually also got a question about pregnant women and the block grant option in the legislation. So can you talk about what is the option for states to do a block grant instead of per capita caps? I believe that's mostly pertaining to pregnant women and non-disabled adults, but can you kind of explain what the proposal actually is, and then what would that mean, and what incentives would that put in place for states? Would it put in place incentives to be, to do a better job with maternity outcomes, for example, or not, and if not, why?
Jump in on that? Sure. In terms of incentives to do a better job on maternity outcomes, let me just pick up quickly the point about the status quo. I don't think there's a Medicaid program in the country that is just running on autopilot. There's no status quo in the Medicaid programs. They're incredibly dynamic, and what's been going on really since the end of the Great Recession is a very focused effort on trying to lower costs through care improvements, through better integration of care, through coordination of care, through looking at those high-cost individuals, avoiding emergency room costs, avoiding preventable admissions. Lots and lots of energy going around that. So I don't think any of this discussion around the bill should be, and any of the criticism about the bill should be taken as a statement that there ought to be no change or there is no change in the Medicaid program. In terms of now I'm forgetting, the block grant. The block grant proposal in the Senate is more narrowly drawn than in the House proposal. It's also a lot more detailed than in the House proposal. It would largely be for pregnant women and those very low-income parents that didn't fall into the expansion population. And it would not, unlike a per capita cap, it would not vary. The amount of money that you got would be based on your historic spending, but it wouldn't vary over the years based on the numbers of people that you enroll. So that's a big financing difference between a block grant and a per capita cap. The other thing is in the Senate bill, the growth in the block grant would be at that CPI, that lower trend rate for the entire period of time. So it wouldn't vary based on enrollment, and it wouldn't grow nearly even as much as the per capita caps would, at least until the outer years. They would both grow at that rate. Why would a state want to do that? It does give the states more flexibility. Could lower benefits to pregnant women, reduce requirements in terms of federal requirements in terms of what services are covered or the amount and the scope of those services. But it also has this feature which is kind of hidden, but it allows states to draw down those federal block grant dollars with spending a lot less of their state dollars. So it might also have an attraction to states for that reason.
I'd just say one thing briefly about, I know folks in this room probably know this, but maybe not all the viewers. Cindy described what's in the Senate bill This is likely to go to conference committee, and so the final version of what comes out of this may look different from what we're describing. So, as people are reading the media, they're saying, oh, this is in the House bill, this is in the Senate bill, and I think a lot of Americans assume, well, what's currently being debated will be the final version, and there's no guarantee of that. So I just wanted to mention that this is a moving target, as many of you are aware of.
Thank you. That is a great point. Yeah, we have time for one more question at the mic, if you could keep it brief, and then we'll ask a couple final wrap-up questions.
Thanks, Sarah. My name is Mike Miller, and I'm one of the clinicians that Chuck Ray mentioned that have actually treated patients. And since Richard brought up Ronald Reagan, it made me think that was my first position here in Washington was in the Reagan White House. And not only did he have the misery index, but one thing he was noted for saying was asking the rhetorical question, are you better off now than you were 4 years ago? And I think that's a great way to perceive what's going on with Medicaid and our entire healthcare system, and particularly with the changes that have happened with the ACA, what it means for people on Medicaid, because one of the challenges Medicaid has, and I know Chuck knows this, Cindy knows it, is that there can be a lot of churn between people going into Medicaid, into uninsured, into private insurance, into employment-based insurance, that kind of things. So I'm wondering if Cindy or Chuck or Melinda can talk a little bit about how the challenges of a Medicaid program dealing with those people going in and out of different insurance eligibility coverages, and how the current situation, I won't call it the status quo, makes their lives better and makes it simpler for insurance coverage and continuation of coverage. Thank you.
A number of ways in which the Affordable Care Act and also just states' decisions about how they're implementing the Affordable Care Act, whether they're an expansion state or not, but that has reduced churning in the Medicaid program. It's not that it's not continuing to be an issue. There is still, a lot of in and out. But a lot of the simplifications of the enrollment process and the renewal process has meant that paperwork barriers that have kept people from being covered continuously as long as they're eligible are in place. And the benefits of that really go to some of the issues we were just talking about in terms of what states are working on, which is if you're really trying to get at those high-cost case individuals, if you're really trying to change the trajectory of their health, then you need to have their lives covered. You need to be connected to them for a continuous period of time. So the churning is both good for people because they can access their care, but it is also good for the goals of helping to improve the management of care and to bring down that cost curve.
So just a super quick note on that. I mean, I think some of this sounds like, from Josh, what you were saying earlier about kind of trying to get people off of the Medicaid program as soon as possible. So some of this kind of depends on how you view the Medicaid program. Should it be like a temporary source of assistance or, a longer term kind of health insurance program? Maybe just to point that out. Okay, well, we have a few minutes left, and we certainly haven't solved all the problems today, but we've certainly had a robust discussion. I guess I just want to close by asking each of the panelists in 30 seconds or less. I mean, if you could wave your magic wand and make one change or state one principle about this program, what would it be? And that's about kind of all we'll have time for, and then we'll wrap it up. We start with Richard because we've been.
Well, if you don't mind, I'll take my time. I also want to issue what I think is a correction, which is there's an impression that somehow the evidence out there suggests that from the Oregon experiment is that there's no benefit to Medicaid in terms of health. And somehow everybody seems to skip over the fact that mental illnesses and diabetes are both sicknesses that cost this country a lot of money. In fact, diabetes is probably the most expensive single illness in the country, and those are the places that the Oregon experiment had their biggest effect. And somehow people keep skipping that part, and I don't understand it. But for me, I guess I think there is a lot of flexibility in Medicaid. I do think that some of the problems have been sort of chronic, underpayment in certain areas. And that's because, in a sense, we've used prices to control supply. And I do think the advantage of managed care, apologies to Chuck, is that in fact it allows greater flexibility on that front and allows sort of more of a mainstreaming of the delivery system into in the Medicaid program.
And I'll accept that criticism. I think, if I had a magic wand and I could wave it and I could fix Medicaid and the rest of the health system, I think there's just one answer. I mean, you have to look at the most economical and efficient systems that we have already operating in the United States, and that's Medicare. And so I think Bernie Sanders said it, and I'll go right there. If I had a magic wand, I think we need a single payer system if we're going to be able to provide coverage for everybody.
All right, Josh.
I'll take a slightly different tact. If I had a magic wand, I would hope that our conversation about Medicaid would stop assuming it can fix all of our problems and actually take a critical eye to say, if we're really robust, critical public policymakers, we're going to see if there's a better way to do it and do it that way instead, if it's better, whether it's opioid treatment or others, instead of assuming that a managed care plastic card solves all of our problems.
Well, where I'd wave my wand, I suppose, depends on the day or the week. But I'm focused on what's going on here in the Congress, so I'll talk about my wand relative to the discussion at present. Medicaid's not perfect. No program's perfect. It's evolving. It's changing. It's growing. It's developing. But what seems pretty clear to me, having experience in the program for quite a number of years, is that just cutting off expansion funding that has supported the growth of people being able to get coverage for the first time and get care for the first time, consistent, regular care, and just arbitrarily capping the federal contributions and saying we're going to give you this much and no more is not solving our health care problems. It's not improving health outcomes. It's guaranteeing the federal government some savings, but I don't think it's tackling any of the big issues that are before the nation in terms of health care costs or health outcomes.
Well, to tackling the big issues, thank you all so much. If I could wave my magic wand, you guys would all fill out your blue evaluation forms. So hopefully you'll do that before you go home for the afternoon. That's easy. Thank you all. Thank you to our panelists. Really appreciate you being here.